Okay, so we are going to do a short video on sickle cell anemia. So sickle cell anemia is a hemoglobinopathy, okay? With sickle cell, you find that the normal hemoglobin is replaced with this abnormal hemoglobin S, these sickle cell hemoglobins, okay? Sickle cell disease is another one, just like cystic fibrosis, actually. It is a recessive disease. So you have to have two carriers of sickle cell to have a child with sickle cell, okay? There are different versions of sickle cell. Don't necessarily stress yourself out with this. This is not something that any NCLEX is ever really going to need you to know, and it's not something until like somebody is like a hematologist that they're going to be able to really break it out perfectly. Even talking to like the hemonc nurses on 4-Weaver, they can give you kind of a good idea of this stuff, but it's still quite complicated. So things like there is sickle cell anemia, just the hemoglobin SS, and then there's sickle cell C disease. So it's a different type of sickle cell. You can have a patient that is a carrier of one, and then another patient that's a carrier of another, and yes, your child can be affected. That 25% chance of being affected. You can also have thalassemia disease. So beta thalassemia, for example, is another type of hemoglobinopathy, very similar to sickle cell. And that your kid could be affected. So I remember when I did my peds rotation in school, I had a little girl that was really close to. I got to take care of her at least 2-3 weeks together, and she had beta thalassemia and sickle cell, and she was a sick little girl. So you don't necessarily need to get into the details. Just be aware that there's different ones. That's all. So it is an autosomal recessive disorder, like I was saying. 9% of African Americans are carriers. 40% of Native Africans are carriers. Interesting about sickle cell, so it is I would say a genetic adaptation. And what's interesting about it is that it's actually a protective factor against another not common, but a very deadly disease. So sickle cell is a protective factor against the malaria, right? So it's basically our theory is like, obviously we don't have perfect evidence that this is exactly what happened and why it happened, but looking at genetics, it is likely an adaptation to survive malaria that kind of came out from malaria being so rampant. And so a person that's a carrier of sickle cell actually has kind of the best of both worlds. They don't have sickle cell specifically, and they are protected against malaria, at least in Africa, where they can definitely be exposed to it. They kind of have the best of both worlds. Obviously, the risk of having a child with sickle cell, though, I'm not sure that really outweighs it. But so if you have two parents that have the trait, each of their children has a 25% chance of having the disease. And then, in areas where malaria is common, individuals with the sickle cell trait actually have a survival advantage over the people that don't have it. Okay, I unfortunately deleted everything from this slide. I probably should have mentioned I slept like 2 hours since my night shift, so I'm doing my best in these videos. I apologize if they're a little bit confusing. You can give me that feedback later. Okay, so clinical features of sickle cell. So what happens is you have these RBCs, and actually they start out basically looking normal, or sickle hemoglobins. They actually start out looking normal, and you should have learned and gone over the triggers of sickle cell crisis or sickling of the cells when you did your simulation. If you haven't gotten a chance to do that, everybody should be able to do it before the final. I think it really helps to be able to envision what sickle cell actually is, especially the triggers for a sickle cell crisis. And so what you see is when you have a trigger, things like dehydration, things like infection, things like increase in temperature, temperature changes even, changes in elevation, these kinds of things can be triggers for sickle cell. Infection, that kind of stuff. So when you have a trigger, you have the sickling of the cells. And what ends up happening is you see this backup of the sickle cells blocking this blood vessel. So remember we talked about perfusion, we talked about the localized effect when you have a problem with perfusion. And we discussed how it relates to acute compartment syndrome. Well, it also relates to sickle cell as well. So things like tissue necrosis, things like myocardial infarction, pulmonary embolism, DVT, stroke, all of those things are also associated with that localized perfusion. It's just a little bit more important organs, right? So we have this block of the sickling of the cells, and it blocks that perfusion to that area. So you have that cellular death, okay? And then you also have increased RBC destruction. So anytime you're thinking about increased RBC destruction, you should be thinking about two organs. The liver and the spleen are heavily associated with our RBC destruction. So we can see issues with that as well in our sickle cell patients. Okay. So some of the complications you can see is things like stroke. I remember I took care of a kid. I want to say he was 14, and he had already had 2 strokes. So very, very common in sickle cell. Things like retinopathy, blindness, so issues with their eyes, issues with, we just talked about the hepatomegaly, and you could say hepatosplenomegaly, issues with both of the liver and the spleen. The splenic sequestration, so that is actually considered one of the emergencies that we'll talk about with sickle cell, where you have significant blockage in that spleen, and the spleen can burst and we can have a hemorrhage on our hands. So definitely a huge risk. Things like having priapism. So this is where we have a patient that has an erection for a very long time, and it's caused by the sickling of the cells. It's actually very common in our male sickle cell patients. As common as once they hit teens, it can happen quite often. And again, we want to help relieve that sickling of the cells, because cellular death is the risk with it. So like we talked about, that's definitely huge risk. So things like also osteomyelitis, anything where we have that decrease in perfusion is a huge concern, right? So what do we want to do? We want to prevent the sickling. So we want to prevent things like infection. We want to prevent temperature changes. We want to talk to them about hydration. You remember you did the little Brittany, you want to make sure she drinks her juice. About elevation, going to the mountains, having like a lower oxygenated environment can definitely trigger a sickle cell crisis. Just temperature changes in general, cold and hot. If it's really hot, making sure that they know to hydrate. It's not that the kid can't go play outside, but they just need to know how to do it, how to keep themselves safe, right? So it's really important. Really don't want them smoking, don't want them around somebody that's smoking. Any of that kind of stuff can definitely trigger a sickle cell crisis for them as well. Managing their electrolytes, not just hydration, but also making sure that they have electrolyte replacement as well. Pain control. Pain control is actually really important for sickle cell. And a lot of times people think like, okay, first of all, let's just talk about sickle cell in general. If you want to get me a little bit hot about pain control and our sickle cell patients, go with me to clinical and then dismiss a patient that has sickle cell, their pain. That will definitely, that's a trigger for me. I feel very strongly about the fact that a patient that's been in chronic pain, they are not going to present the same way that a patient that doesn't have chronic pain is going to present. So if they tell you they're a 10 out of 10, but they're eating potato chips, they might just be hungry, right? So pain is a way to help their sickle crisis. Okay, why? Because what happens with pain? It's stress. It's a stressor. And when they're in significant amount of pain, that stress can actually cause more sickling, more pain on top of it. So pain is definitely important. Blood replacement. So blood replacement is also important. So making sure now, of course, they're going to be stable on a lower hemoglobin hematocrit than your normal patients because they are typically at that point, so they've compensated for it. They're okay. But we do want to target when they're unstable. Okay, so doing the blood replacement when it's specifically needed. The more blood transfusions that we do, the higher risk we have of more complications, actually. Things like having an antibody on their own blood screen. So, for example, the kid that was 14, he had very, very specific type of antibody that was on his blood. He needed a very specific type of blood. We had to wait for like a week to get his blood from One Blood. And then also making sure that they're on antibiotics. They have a high risk of having pneumonia and also what's called acute chest syndrome. Very, very similar to pneumonia as well. So it's like a little bit of pulmonary embolism with pneumonia mixed in. And so a lot of times they'll have them on antibiotics in that early stages, especially when they're in the ped stage, and then it depends on how much pneumonia they've had and whether they're going to take them off of it again. Okay, so penicillin is typically what you'll see them on. So there is no cure except bone marrow transplantation if available. Remember, it is really only associated with good outcomes if you can have like a sibling match and high chance of having complications whenever we're decreasing their bone marrow, reducing it, and then also that graft versus host disease, huge complication. And it may not be a cure. The sickle cell might still come back. And so preventing those sickling episodes, doing things to prevent like frequent bacterial infections, that kind of thing. And that's where that having them on prophylactic penicillin can become really important. And I think there's another slide on the medications, but I'll talk about it in a second. So we would want to educate the family and the child about sickle cell disease and recognizing the signs of a stroke, respiratory problems like the acute chest syndrome. It's typically chest pain, difficulty breathing, shortness of breath. Making sure that they also know that they're still a kid and that they should be treated just like a kid, okay? So recognizing the things that can precipitate a sickle cell crisis like trauma, infection, fever, physical and emotional stress as well. Anything that can increase their blood viscosity like dehydration, hypoxia, low oxygen, those kinds of things. So that's where that elevation definitely comes into play. And to treat it, doing things like allowing for as much rest to minimize energy loss is important. Hydration, whether it's through oral or IV therapy. Hydration is one of the most important things for sickle cell crisis because if we can hydrate them, we can hopefully get perfusion around that block, okay? And then it's also going to help prevent more sickling of cells. So hydration is one of the primary things, okay? And then the electrolyte replacement might be a consideration. Analgesia, right? So their pain. Pain is also one of those primary things that we want to think about. So oxygen a lot of times you'll see associated with sickle cell as well. Oxygen is very much directed towards their SpO2. So we used to just kind of put them on oxygen automatically because we knew hypoxia could cause it, but we found that it really should just be directed towards their SpO2. So if their SpO2, for example, is like less than 93%, then we would consider doing oxygen. Blood replacement for anemia, again, a lot of times they're more stable than we would be at, like, say, 8 and 24, but so we're going to do it based upon their symptoms and their need. However, sometimes doing blood replacement with the sickle cell crisis can actually improve their outcomes. And then antibiotics for infection. Some other things that we can do. So the prophylactic antibiotics we talked about, 2 months to 5 years is typically what you'll see for the kids. And then it really depends on how much acute stress syndrome and pneumonia they've had during that time. Monitoring the reticulocyte count regularly to evaluate the bone marrow effects of function, and blood transfusion if early in crisis can help reduce the ischemia. And then I'm going to write a medication. It might be on here. But I'm going to write it on here just in case it's not, and you guys can make fun of my horrible handwriting, I know. Hydroxyurea. So hydroxyurea is a really interesting medication that we give sickle cell patients, because what this medication does is it increases, and this is, you're going to be like, why is she talking about fetuses and C7? So it increases fetal hemoglobin. So fetal hemoglobin is actually a protective factor against sickle cell anemia. It is like resistant to the sickle cell aspect, right? So if we can increase their fetal hemoglobin, we can give them more effective hemoglobin that's not going to sickle. So hydroxyurea actually increases their fetal hemoglobin, which I think is super cool. So that's one of the medications that we use to manage sickle cell. So some of the really scary things that can happen in sickle cell. Vaso-occlusive crisis. So this is our sickle cell crisis is another way that we typically think of with sickle cell or vaso-occlusive crisis. Anytime that we have an occlusion in our joints and our throughout our body, one of the very first signs that they can have is pain. So it can happen typically if we're talking about like abdominal pain or pain in their joints. They might have swelling of their hands or their feet or their joints specifically, because that's where that occlusion is. So pain is one of the biggest issues. The big thing that we want to prevent is any ischemia or infarction. And then another one of those really scary things, splenic sequestration. So it's caused by a pooling and clumping of the blood in the spleen, or hypersplenism is another term for it. Things you can see: profound anemia, hypovolemia, and shock. Okay, this can cause huge complications with your patient. And they can have just that, it can be the abdominal pain can be one of the signs for it. Okay. And so this is why a lot of times your sickle cell patients have had a splenectomy. They've had their spleen removed at some point. Hyperhemolytic crisis. So this is where we have extreme amount of our RBC destruction. So what are we worried about there? We're worried about our liver, right? Our liver is heavily affected by this. So we see anemia, jaundice, reticulocytosis, which means we have a whole bunch of little reticulocytes, but nothing that's very effective. And then aplastic crisis. So our aplastic crisis is where we have a huge amount of destruction of our RBCs. It can be triggered by a viral infection. or depletion of folic acid. Folic acid is also one of the things that we would give our sickle cell patients because it helps the creation of RBCs. So if they have aplastic crisis, we can see profound anemia and pallor. Okay. The clinic nurse instructs parents of a child with sickle cell anemia about the precipitating factors related to sickle cell crisis. Which is identified as the parents as a precipitating factor indicates the need for further instruction. If you said, so stress, trauma, infection, or fluid overload. If you said fluid overload, you're correct. So fluid overload is not a concern with sickle cell. Now, I will say one little exception about that is that if they do end up getting heart failure, we might be watching their fluids, but we're still not going to be restricting their fluids like you would any other heart failure patient. So we actually increase their fluids significantly in comparison to our normal patient. So they actually take 1.5 to 2 times the daily requirement of fluids to prevent hydration. Right. So you and I, when I'm not working out and it's just a normal day, you're hanging around, you should probably drink about 2 liters of fluid. That's a lot, right? Most people don't even realize that most people do not drink as much fluid as they're supposed to. So if you're saying that they need to drink 1.5 to 2 times the amount of fluid, so what is that? So you're looking about 3,000 milliliters to even as much as 3,000 to 4,000 liters. So that's a significant amount of fluid for an adult. Okay. Nurses reviewing a healthcare provider's prescriptions for a child with sickle cell anemia who is admitted to the hospital for a treatment of vaso-occlusive crisis. Which prescriptions documented in the child's record should the nurse question? Select all that apply. 1. Restrict fluid intake. 2. Position for comfort. 3. Avoid strain on painful joints. 4. Apply nasal oxygen at 2 liters per minute. 5. Provide a high-calorie, high-protein diet. 6. Give meperidine 25 milligrams intravenously every 4 hours for pain. Okay, so the answer is 1 and 6. We don't restrict fluids. And remember, meperidine isn't just bad in our elderly. It's also a concern in our sickle cell patients, okay? Highly associated with things, the scary, horrible things that can cause like tremors, myoclonus, seizures is one of the big things that we see with sickle cell with meperidine. Everything else is totally acceptable. Even the oxygen, if they need it, then they need it. So it's not going to be something that you'd question. And most likely it's going to say something like PRN or per their SpO2 anyways, if it's an oxygen order. Okay. So we're going to do a little case study. A 15-year-old presents to the ER with a fever that has persisted all day, along with dizziness. He has a history of sickle cell disease, diagnosed as a newborn. Remember, it's done through the metabolic screening. Temperature 102.7, blood pressure is 109/55, heart rate's 120 beats per minute, respiratory rate is 24 beats per minute, it's 98% on room air, cap refills 3 seconds. Extremity pulses are +3, abdominal and chest pain rated as a 6 out of 10 in the numeric pain scale. So what are the cues that we look at here? So yeah, our temperature of 102.7, absolutely. We know that that is definitely a trigger for a sickle cell crisis. Heart rate's 120 beats per minute. That is definitely a tachycardia that he has right now. Respiratory rate is 24 beats per minute, and he has abdominal and chest pain rated as a 6 out of 10 on the numeric pain scale. So if you're thinking, gosh, I remember she said that pneumonia and acute chest syndrome are really, really big risk factors for our sickle cell patients, and this patient seems to have a really high temperature, a fast heart rate, and is tachypnic. I wonder if it's that one. You are correct. That would be one of our differential diagnoses or our concerns, right? Okay. Any questions? Hopefully you'll bring them in class. Thank you.